Welcome to This Week in Dermatology. This week we're covering 10 notable papers spanning inflammatory skin disease and its systemic burden, new mechanisms and management frameworks in atopic dermatitis and alopecia areata, and diagnostics for the conditions we most often miss: subclinical basal cell carcinoma, VEXAS syndrome, and male genital lichen sclerosus. Let's dive in. We start with atopic dermatitis, where the Lancet published the full 16-week induction results of REZOL VEADA Phase 2b trial of respegalduslucan, an interleukin-2 receptor agonist designed to selectively expand regulatory T cells rather than block a cytokine. Silverberg and colleagues randomized 398 biologic-naive adults with moderate to severe disease across 107 sites in 10 countries to one of 3 subcutaneous dose regimens or placebo. All 3 active arms met the primary endpoint, and the response was dose-dependent. The highest dose given every 2 weeks reduced eczema area and severity index scores by about 60%, roughly double the 30% improvement seen with placebo, giving a treatment difference of about 30 percentage points. The lower dose and the every 4-week regimen fell in between. What makes this worth watching is the mechanism: a TREG-directed strategy rather than interleukin 4, 13, or 31 blockade, or Janus kinase inhibition, which raises the prospect of durable immune re-regulation off-drug. That question is not answered by a 16-week induction period, and this remains Phase 2b, so nothing changes in the clinic today. Alongside that, Acta Dermatovenereologica adds to the debate about what atopic dermatitis does beyond the skin. In a cross-sectional study of 50 adults with moderate to severe disease and 50 controls, Sanabria de la Torre and colleagues found patients carried a heavier cardiometabolic load, higher body mass index around 27 versus 25, mean arterial pressure roughly 10 millimeters of mercury higher, markedly higher C-reactive protein, poorer Mediterranean diet adherence, and less physical activity. Estimated 10-year cardiovascular risk by the PREVENT equations was significantly higher in patients than controls, and greater disease severity tracked with higher fasting glucose and heart rate. This is a small, single snapshot study that cannot separate inflammation from lifestyle, but it supports what many of us already do: checking blood pressure, weight, and lipids in patients with severe eczema, rather than assuming someone else has. Turning to hidradenitis suppurativa, 2 papers in the Journal of the European Academy of Dermatology and Venereology land in the same week and speak directly to each other. Jemek and colleagues published Part 1 of the European S2K guidelines, updating the 2015 S1 document and covering epidemiology, diagnosis, clinometrics, and comorbidities, with treatment held over to Part 2. These are consensus-based recommendations built through a Delphi process and pitched deliberately at the generalist, which matters because most patients with hidradenitis are still diagnosed years late by clinicians who see the condition infrequently. The companion paper is a real-world reality check on how we grade severity. Pascual and colleagues reported baseline data from the Spanish hidradenitis suppurativa registry, 1,188 patients with a mean age of 37, assessed with the disease-specific high QoL instrument. The mean score of just over 24 sits in the very severe impairment range for the cohort as a whole. The striking finding is that nearly 4 in 10 patients with Hurley stage 1 disease, the group we routinely call mild, reported very severe quality of life impairment. Worse scores clustered with female sex, smoking, anxiety and depression, greater pain, inflammatory and mixed phenotypes, and particular lesion sites. The practical message is that Hurley stage is a poor proxy for suffering, and if you are using anatomical staging alone to decide who needs systemic therapy or mental health support, you will systematically undertreat a large minority of your patients. Adding a patient-reported measure to the visit is cheap and changes decisions. The Journal of the American Academy of Dermatology gives us a paired review of alopecia areata that together amount to a current management framework. Moss and colleagues cover evaluation and pathogenesis, reminding us that the condition affects roughly 2% of people globally, that trichoscopy findings such as black dot and exclamation point hairs should be documented, and that pathogenesis centers on collapse of follicular immune privilege with cytotoxic CD8 T-cell inflammation, with genetic and pharmacologic evidence pointing to the JAK-STAT pathway and a Th2 contribution in some patients. The companion paper from Spindler and colleagues translates that into treatment. The historic threshold of a severity of alopecia tool score of 50 or more to define severe disease is being supplemented by the alopecia areata scale for clinical use, which incorporates eyebrow and eyelash loss, psychosocial impairment, and treatment response. For milder disease, topical or intralesional corticosteroids with topical or oral minoxidil remain first line, and observation is still defensible given the potential for spontaneous regrowth. For severe disease, the choice among baricitinib, ritlecitinib, and deoxyritinib turns on age, comorbidity, monitoring burden, and insurance. And the point worth remembering, switching between Janus kinase inhibitors can still help after failure of one agent. That same broadening of severity assessment, beyond a percentage of scalp surface, echoes the hidradenitis data. In both diseases, the field is moving from anatomy toward burden. Finally, 3 papers on recognizing what we would otherwise miss. In JAMA Dermatology, Ronicky and colleagues tested line field confocal optical coherence tomography, paired with artificial intelligence image recognition, as a screening tool in 150 inpatients with at least 2 basal cell carcinoma risk factors, mean age 73. After excluding any lesion that looked suspicious to the naked eye, they systematically imaged normal-appearing facial skin and found 17 subclinical basal cell carcinomas in 14 patients, so roughly 1 in 11 high-risk patients harbored an occult tumor. Of the 18 lesions flagged by the system, 15 were histologically confirmed, a positive predictive value of about 83%, with a single false positive that turned out to be an actinic keratosis. Around 3/4 of the cancers were superficial, and subtype classification was correct in 13 of 15 cases. This is a feasibility study. Sensitivity was not assessed, and the authors are explicit that we do not yet know whether finding these lesions earlier improves outcomes or justifies the cost. A genuine overdiagnosis question in a group with a mean age in the 70s. Also in the Journal of the American Academy of Dermatology, a 2-part continuing education series on VEXAS syndrome makes the case that dermatologists are often the first to see it, because cutaneous findings are frequent and commonly precede multi-organ disease. Part 2 walks through the workup, characteristic laboratory abnormalities, bone marrow vacuoles, and definitive UBA1 genetic testing, plus management with glucocorticoids, steroid-sparing agents, hypomethylating agents, and allogeneic stem cell transplantation, and prognostic drivers including variant type, clonal burden, and progression to myelodysplastic syndrome. The trigger to remember: an older man with treatment-refractory neutrophilic dermatosis, systemic inflammation, and cytopenias deserves UBA1 testing rather than another course of steroids. And in the European Journal, Kravas and colleagues review male genital lichen sclerosus, arguing that chronic occluded exposure of susceptible epithelium to urine is central to pathogenesis, supported by the lesion distribution, the high remission rate after circumcision, and the rarity of disease in neonatally circumcised men. Potent topical corticosteroids remain first line, circumcision is highly effective when they fail, and the association with differentiated penile intraepithelial neoplasia and penile squamous cell carcinoma, independent of human papillomavirus, is the reason these men need ongoing follow-up rather than a single prescription. If you only have time for one paper this week, make it the Spanish Registry Analysis of Quality of Life in Hidradenitis Suppurativa. It is the one finding you can act on at your next clinic. Hurley Stage 1 does not mean mild patient experience, and a disease-specific patient-reported score will change who you escalate. Here are the key takeaways from this week in dermatology. First, a regulatory T-cell-directed agent has now shown dose-dependent, placebo-beating efficacy in moderate to severe atopic dermatitis at 16 weeks, opening a mechanism distinct from cytokine blockade. But this is Phase 2b, and durability is unknown. Second, adults with moderate to severe eczema carry a measurably worse cardiometabolic profile, so build blood pressure, weight, and metabolic screening into severe disease care. Third, In hidradenitis suppurativa, anatomical staging underdetects burden. Use the new European guidance for diagnosis and comorbidity screening and add a patient-reported outcome. Fourth, in alopecia areata, severity assessment now includes eyebrow and eyelash loss and psychosocial impact, and non-response to one Janus kinase inhibitor does not preclude response to another. Fifth, keep VEXAS syndrome on your differential for refractory inflammatory skin disease with cytopenias in older men, and treat artificial intelligence-assisted confocal imaging for occult basal cell carcinoma as promising but unproven. That's your roundup for this week in dermatology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And a quick rating on Apple Podcasts or Spotify helps other physicians discover the show. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.